On this week's episode of the Physio Foundations podcast, I'm talking to Associate Professor Laura Diam, who's a biomedical engineer and a researcher interested in hip biomechanics and osteoarthritis. Welcome back to the Physio Foundations podcast, where we talk about the knowledge and skills that provide the foundation of expert clinical practice. So today I'm talking to Associate Professor Laura Diam. So Laura is an old friend of mine from the University of Melbourne PhD days, where we did our PhD together, and currently an associate professor in the School of Health Sciences and Social Work at Griffith University in the Gold Coast, up on the sunny part of Australia on the East Coast. And Laura's also a research leader in the Griffith Centre of Biomedical and Rehabilitation Engineering, and holds an honorary research fellow position in the School of Health and Rehab Sciences at the University of Queensland. So she's very busy. And since I last hung out with Laura, she's achieved quite a lot of things. I might just chat to her about them rather than reading out her bio. So Laura, good to see you again. Welcome to Physio Foundations.
Yeah, thanks, Luke. It's really great to be here and nice to catch up with an old friend and have the chance to chat with you about science, just like we did in the old days.
Oh, sure. Well, let's get into the science, but tell everyone a little bit more about what you've done in the last 10 years since we did our PhDs together. So you originally trained as a biomedical engineer, and that was, how do we say it? Dalhousie University in Canada?
Yeah, that's right. In Canada. Yeah, that's absolutely right. So I did my undergrad in engineering and my master's in biomechanics in Canada, where I'm from, way over on the East Coast. I'm from a little place called Prince Edward Island. Most people haven't heard of it here in Australia, but north of New York and Boston. And I went to uni there, and then, I was ready to see the world, and I was interested in some of the exciting biomechanics research and osteoarthritis happening here in Australia. And that's what led me to the University of Melbourne, and where our worlds collided there. Since that time, after our PhD, I accepted a position here at Griffith University, which was an academic position at the time. So a combined teaching and research position. Since then, I've been very fortunate to get an NHMRC investigator grant fellowship, which just means that I've been able to focus solely on research for the last couple of years. And so most of the things that are exciting for me, as you know, it's been all about the hips for me since I came to Australia. And I suppose understanding musculoskeletal and orthopedic conditions in general. So up here at Griffith, we develop and apply technology, and I'm sure we'll talk about some of those, to really better understand musculoskeletal and orthopedic conditions, and also to develop targeted treatments with a biomechanics focus. So biomechanics being understanding and changing the way that people move and how they might apply load to their cartilage and their bones and so on. Yeah, so that's me. And now I've got quite a few PhD students of my own, but it's really fun being on the other side and having the opportunity to mentor undergraduate students in exercise science, or honor students in physio, or PhD students, whatever the case may be.
And you've been really successful. You touched on your NHMRC fellowship, but just for those who are just thinking about research in the future, or perhaps even still studying and in their entry to practice degree, that's not an easy thing to get. So that's a very big achievement. And so to be a researcher that's funded by your own fellowship is a lifetime of work to get there. So congratulations for that. And I think you've got over 70 published papers, a lot of them on the hip joints or osteoarthritis and related topics, and other prizes, and lots of things got you to the position you're in now.
Oh, thanks, Luke. Look, of course, it's, as a researcher, it is a bit daunting, I suppose, in a way, when you're needing to acquire grant funding, which is very competitive, of course, around the country, to develop your research program and fund your staff and so on. But I think for people starting out at the undergraduate level, or you don't need a lot of money. What you really need is curiosity and an interest in finding out something new, or digging a little bit deeper into that problem that you might have noticed clinically, but that potentially a research experiment might provide more insight into. So I think you know, that those are the things that I face now, the challenges in grant funding. But I think how it all started for me was a genuine curiosity in what it is that we can learn in terms of health and the innovative technology that we can develop to treat these clinical problems.
Mm. And that'll be one of those key skills we'll come back to at the final question that we always do about foundational knowledge and skills for practitioners or anyone listening to it. And one of them that's come up a lot has been curiosity and having that drive for knowledge and lifelong learning. But let's talk about your research. Let's talk about some highlights, some key papers that you've published,
yeah, sure.
what they might mean, and then we'll go into the weeds from there.
Yeah, cool. That sounds good, Luke. Yeah, well, as you said, I've published across hip and knee, and some we use certain techniques in modeling, and I think we'll talk a little bit more about experimental approaches we use in measuring muscle activations and so on. And while that's all very exciting, I think my real passion is understanding the hip joint and identifying potential treatment targets for people that do have hip pain, whether it's young athletes with femoral acetabular impingement syndrome. And, I did my PhD in that area. But of course, these people are at high risk of going on to develop hip osteoarthritis early in life. And even for those that are a little bit later in life, I see my parents going through it now, developing osteoarthritis, and the opportunity to intervene effectively so that people can stay active and potentially avoid surgery, which can be costly and often avoidable. So some key highlights. Well, that's always a bit tough. I think one of the questions that I always had, and sort of was an extension of my PhD, where I focused on the deep hip muscles, was, well, what are these muscles doing? I mean, of course, we can read in textbooks, and we can, as an expert in anatomy, you obviously can understand, lines of actions and, the moment arms and so on. But we really wanted to try to experimentally and computationally understand, can these muscles actually stabilize the hip joint, which is what they've been largely hypothesized to do, and if not, what is it that they're actually capable of doing? Because they can be, I think for many, problematic and often a focus of rehabilitation. So we did a study where we sought to understand what their function was. And this is a previous PhD student of mine. She's just finished, actually, A.V. Minders. And she's over at Carnegie Mellon now doing a research fellowship in the United States. And she did a simulation study of 12 participants when they were walking. And what we did is we used fine wire electrodes, which Luke's had the pleasure of experiencing. Yes. And this was a method that I integrated in my PhD as well. And for those of you listening that might not understand what this is that when we want to measure activation of a muscle that's not on the surface, meaning it's below other muscles, we actually need to insert an electrode into that muscle. And we do that by using a very, very long needle with two wires, insert it within it and with the tips exposed and so on. And we insert it under ultrasound guidance till we're confident that it's within the muscle belly of the muscle that we're trying to measure. And yes, that stays in there while we're having people do two tasks, as you'll remember, Luke.
Yeah,
walking
I remember
and running.
I remember it well.
I think you mean you remember it fondly.
Yes.
No doubt.
Sure.
But we did this experiment to first understand how people actually activate these muscles. But we also simulated what would happen if we activated them to their maximum amount. So, of course, we had people do maximum isometric contractions, but these weren't but we also simulated what would happen if we maximally activated all of these muscles. And we wanted to see if doing that would actually stabilize the joint. And it was interesting because we found out, and again, there's obviously limitations in terms of the method that we used, which was a combined experimental simulation approach. But we found that these muscles weren't actually stabilizing the joint, but they had another potentially really important function. They were actually able to change the direction of loading within the joint. So loading meaning, I guess like simplistically, you can think of it as the combined load that all of the muscles are generating together within the hip joint. And by activating these muscles maximally through simulation, we showed that we could redirect the hip contact force away from the acetabular rim, which is obviously an area that's commonly damaged in some of the pathological groups that I mentioned. So it was quite exciting to think, okay, well, they do have a really important function. And it's just about, I think, moving forward, some of the open questions are whether or not we can actually retrain people to activate them maximally, because we were simulating that aspect. And if doing so does change the locational load, and how does that actually in turn affect osteoarthritic processes, whether it's preventing people from eventually developing it or slowing that process for those with established osteoarthritis.
You would think that people would maximally activate those muscles during maximum effort tasks, so during resistance training, but you don't know unless you measure it, do you?
That's exactly right. And I think that's where things get tricky, right? So where we really want to go, and this is maybe something we were going to talk a little bit later about, is being able to measure these muscles in real time. So, for example, while someone is performing their targeted rehabilitation, are they actually activating these muscles or generating the maximum possible amount of force during these exercises? Or is there a way that we can better target these specific muscles if we know that they're ultimately responsible for changing an important causal effect of disease? So it's there's lots of work to be done there, but I think it's we were very excited about learning something new in terms of the function of the deep hip muscles and their potential capacity for changing loading at the joint.
Yeah, it's really interesting. To go back to your methods, so you were looking at walking and you were determining using musculoskeletal modeling, so using all the reflective markers and all of the force plates and all of those measurements, and EMG, so electromyography, so measuring muscles activation in real time, and then using these models to model whereabouts in the acetabulum most of the force is. And then during the simulation of a maximum contraction of the deep hip muscles, there was a change in where that loading was on the acetabulum, and therefore potentially training or having better activation of those muscles during walking could change the loading of the hip. And it could, and we're saying could or may because we don't know, but over time that could change the course of or progression of osteoarthritis of the hip. Is that my layman's summary? Okay.
I think that was a great summary, and I think you really nailed it in terms of using that cautious language. There's so much that we don't know, and we need to build our evidence here before, of course, we would necessarily change what we're doing clinically. But I think it's exciting to know that this is a possibility. Like the next thing will be to establish, can we even get people to activate these muscles maximally? What does it take to do that? And is that, instantaneously going to change the directional load? Well, is that necessarily enough, or is it something that we need to retrain someone over prolonged periods so that they are like through gait retraining, for example, doing this over the long term. So, but I guess that's what's exciting as a researcher, right? Every time we find out something new, it just leads to many, many, many more questions. So there's always something to be trying to uncover.
Yeah. It may be not your field, you may not have looked at this, but just from your general knowledge, does over time, if people have pain in around the hip or associated with osteoarthritis, do you get changes in the morphology of those muscles in the same way that you do in the lower back or the lateral hip muscles, as Susanna has found in her PhD, which we need to do an episode on that soon, or other muscle groups around the body? You get changes in the fat infiltrate and cross-sectional area?
Yeah, absolutely. And, I'm sure you're across this, but just for listeners, there's lots of evidence that people with established osteoarthritis or even long-term, I suppose, hip pain, depending on the source of the pain, have different smaller muscles, more fatty infiltration, and reduced function as well. So it could be for those things that we observed in a study of people with established hip osteoarthritis that although they were trying to contract their muscles more, so higher levels of co-contraction, it actually didn't generate more loading at the joint. And the likely reason for that is that they are not able to generate as much force, even though they're contracting their muscles more. So there's a bit of a sort of refute some previous assumptions about co-contraction, in that co-contraction alone doesn't necessarily mean the joint will be loaded more, because of course, like as you've already identified, it's more than just activating their muscles. It's their composition, it's their size, strength, and so on. So there's all a significant interplay, and that's what one of the benefits of a musculoskeletal model is, that we can potentially factor in all of these things in a highly personalized model.
Mm. And the deep hip muscles have a completely different angle of pull and moment
That's
arm
right.
With relation to the center of axis of movement with the hip joint than the prime movers, glute max and other muscles.
That's
so
exactly
they're
right.
doing a different thing, aren't they?
They absolutely are. And I think it's when you consider their moment arms and lines of action and their size, and even their shape, you wouldn't be surprised to learn that they're not generating huge amounts of force. And that's what sort of led us to the hypothesis of, well, maybe they're there to instead fine tune movement of the head of the femur in the acetabulum, and that could have potential important implications, long term over cartilage health, for example.
Mm. And for our physio students learning their anatomy for the first time, or the grads going, whoops, I better go back and learn my anatomy again. So you've got hyaline cartilage within the hip joint, the acetabulum, the fibrocartilage labrum around the outside, and then obviously pathology of the labrum and the synovium can be painful. Cartilage is aneural, but it can be painful over time with loading and degradation of the cartilage. So what do you think? Is there enough movement? Is there enough change there in the position of the head of femur to sort of take pressure off the labrum and pressure off those peripheral structures? Is that the hypothesis?
It absolutely is the hypothesis. But at this stage, we will go on to test that experimentally. But our theory is that it absolutely is enough. I'd have to go back to the paper actually, and I can send that to you if you share it with your listeners. But
yeah, sure.
The change in angle was significant enough that you would be moved much more towards the center, which in theory would be an area of cartilage. For those that don't know, the cartilage is not spread evenly across the acetabulum or over the head of the femur. There's two cartilages there. But it would be moving it towards an area of the cartilage that's better able to withstand load, as opposed to at the edge where that's not the case. And as you identified, labral damage is very common, especially in people at risk for osteoarthritis, like femoral acetabular impingement syndrome, which many of the listeners who have a special interest in sports, of course, would no doubt see lots of athletes with hip pain and labral damage. So it's promising. It's exciting to learn, and but lots of work to be done, as I said.
Mm. One of the things I found created a bit of cognitive dissonance in my head when I was thinking about the hip joint and how these muscles might work would be the hip joint's inherently very stable, particularly with a patent labrum and no history of injury and no hip dysplasia. So we talk about the deep hip muscles as stabilizers, or people have, and it sort of makes sense if you think they're sort of pulling the head of the femur into the acetabulum. But there's maybe the language changes slightly based on your research from stabilizing the hip to changing the loading within the cartilage of the hip. That made a lot of sense when you talked about areas of cartilage that are better able to withstand the load and sort of shifting it to a better quality cartilage, perhaps.
Yeah, I think I think you're right on there. And I guess that's one of the I suppose concepts that I was struggling with way back during my PhD was that the hip is inherently stable. It's a joint that's loaded in the direction that increases stability even more. Unlike the shoulder joint, although obviously they're compared very frequently because of their the ball and socket, the ball and socket of the hip, and some of the similar movements in terms of out of plane movements, I suppose, that can be generated at both joints. But um, it is inherently stable, and that's why we sort of developed the curiosity of like what can these small muscles actually contribute in the big scheme of things. Um, are they actually adding value in terms of stability? And we found that they weren't. And obviously, as I said before, this is confined to the experiment that we conducted, and of course, there's always opportunities to expand on that. And we tested sagittal plane rotational hip stiffness. We could, of course, expand that, but our preliminary analysis found that it wasn't as consistent across all planes, that they weren't actually contributing to joint stability. So it is an interesting concept. Obviously, the next thing will be understanding whether we can change load. And there was another paper that we did, which I was really interested in whether or not joint loading was modifiable. We knew we'd already identified that it was a problem in those at risk for OA, so in FAI, and also in established OA. And the interesting thing was that we found that people were not loading their hip joint enough, meaning they had a lower than normal amount of loading at their joint. And there's lots of reasons for that. And that could be a pain avoidance or an altered biomechanics strategy. But it was different to, for example, knee osteoarthritis, where it's well established that people are loading their joint too much. And it's that over or higher amount of loading is actually leading to the cartilage degeneration. So we found the opposite at the hip, and later, several other groups internationally have now found this as well across the spectrum of disease. But that's what sort of led us to realizing, not enough load is just as detrimental to the cartilage as too much load, because cartilage, of course, needs to be stimulated in order to maintain its health. And so it needs a certain amount of loading. And it led us to wonder, well, can we actually increase the load on the cartilage an amount that would theoretically improve cartilage health? And are people able to do this if we try to retrain them? So that's what we did. And we did a lab-based study. So we had participants with osteoarthritis come to the lab, and we provided them with visual feedback, so cues to change the way that they were moving. And this was sort of personalized depending on what their normal walking strategy was. And we did an assessment on that. But nevertheless, when we prescribed them a strategy that was personalized to them, we found that they actually could change the way that they were loading their hip, and they could do it to a magnitude that was, based on the evidence that we have, likely to be beneficial for cartilage health. So it's very exciting. We haven't tested. What we now need to do is establish over the long term whether people continue to move like this, if it is indeed favorable for cartilage health. But we did get people to go home and walk using their prescribed strategy, and found that 3/4 of them or more reported a clinically meaningful improvement in pain, which is awesome. We weren't able to, in this particular study, follow up on their biomechanics to see if they were walking with the strategy we gave them, or do an MRI of their cartilage, for example, to check the structural changes. But it was still it was just a pilot study, but it was exciting result to realize that, okay, we've identified a potentially important mechanism of disease in terms of that lower than normal loading. And now we know that we can modify it to a magnitude that we anticipate will potentially be favorable. So,
what were the strategies? And I know that we'll put the paper in the show notes, and I know you've discussed it already on the Physio Network podcast, which I'll put that link to that episode in there as well. But let's talk about it again here.
Yeah, sure, no problem. So, what we did is, instead of providing people feedback on the actual loading in their joint, which um, we learned from previous studies is sometimes difficult for people to change, and that simple instructions is, of course, from lots of motor learning research, we know are best, because actually changing the way you walk is not easy. It's something that we do so frequently that simple instructions are best. So we had 3 different strategies: one relating to step length, one relating to pelvic tilt, like in the frontal plane, and then the third relating to trunk lean. And we knew from the many biomechanics, hip biomechanics research studies in people with hip osteoarthritis, that these were common gait, I suppose, abnormalities or attributes that people had when they walked, and that, given our knowledge of mechanics, would be likely to change the potential candidates to change hip contact force in the way that we wanted. So we had people walk using all the strategies at first, and some worked better for the others. So we developed a decision tree, which there was obviously the objective component. Could people actually achieve, complete this? Were they comfortable doing it? Did it actually change hip contact force in the direction and of the magnitude range we were hoping, and so on? And then what we did is we prescribed each participant with one of the strategies to take home. And we said, okay, you try for the next 6 weeks, anytime you're out walking, to implement this strategy. And of course, we weren't measuring what they were doing. And that's the next step. And that's what's really exciting about this. And that's sort of where, I guess, the technology comes in. That one of the technologies that we're developing is that what we really want to understand is what people are doing at home. What are they doing that's leading them to seek treatment? Because, if people have pain, for example, and want to go see a physio or a GP or whoever, it's largely related to activities that they're doing on their own. So whether it's sport or climbing stairs at home or whatever the case may be. So without an understanding of what's happening in those moments, there's a large leap to understanding what the problem is.
Well, people should be taking about 10,000 steps a day. You might measure a few of them in a laboratory, and
exactly.
So by measuring people in the real world and getting a good idea of how many of those steps they actually implemented that strategy. So for step length, for example, the mechanism would be you're not stepping as far. Or was it bigger steps?
Yeah, no, you're increasing step length.
Step length in order to actually increase joint
That's right.
Compression or contact forces to improve cartilage health potentially, but you measured the change in symptoms. It's very different from the strategies we might give people when they come in acute pain: load modification, taking fewer steps, gait aids, for example, trying to modify things so they're less painful. You're thinking about cartilage health and loading and long-term, and you get parallels to all the knee osteoarthritis exercise programs that are being used.
Exactly.
They're getting people more active and putting more controlled loading through the cartilage in the joint. It's a really good education point as well, isn't it? So these are the programs that show effectiveness for pain. Actually involve doing more. And if you do less, you could get more pain.
Exactly. And I think it's in some ways counterintuitive. And that's why it's hard, I think, as scientists, but also perhaps for clinicians as well, to initially wrap your head around, because intuitively we think, well, something hurts, let's avoid, and actually patients are often in that mindset. So, and there's lots of literature around behavior change and how to get over that threshold or tolerate that initial pain. But yes, there is lots of research now to show that once that happens and you are exercising and you are loading that joint more and using those muscles more, that will ultimately lead to greater relief in pain. So yes, it is different, because I think conceptually we think, oh, we're overloading the cartilage, it's going to break down. And while that's correct, this is sort of the opposite of that paradigm, where we're saying, well, the cartilage is not getting enough stimulation, so it will ultimately break down as well. So we need to identify what is that sweet spot, which there is some evidence, of course, from cadaveric studies and ex vivo studies, but it will then be about understanding if we can get people to be working in that region in terms of their everyday activities and performing their exercises as well as their functional tasks or sporting tasks or whatever the case may be.
I think that's a really good summary. And although we're talking about biomechanical research and musculoskeletal modelling and all these things that are based in the laboratory, there's quite a lot in that we can think about in the clinic right now for students and grads and other practitioners. Think about it's not just a matter of doing less and resting, the importance of loading as well.
Yeah, exactly right. And I suppose one of the challenges as a clinician I can imagine is that deciding when is the right time for both of those things, because of course you're not going to be loading your joint right after an ACL tear or whatever the case may be. So just about understanding, and we're still learning what that looks like and how much load we want to change and so on. But I think I guess I would recommend for people that are studying or learning, moving into clinical practice, is sort of to try to keep up with the evidence, I think, because there's always new things emerging, and being open to contemporary ways of thinking, I suppose.
Well, I mentioned Physio Network's podcast. They're not paying me a cent, and I don't even know the guys involved, but hello to them, and they're doing great work. And they're an example of a group who is doing summaries of evidence in plain language and on their podcast and all their resources. So there's so much available now for people where you've got really technical, well-designed scientific research going on in laboratories, for example, that you're leading. But then we've got that, that understanding, that translation to the practice, which is part of what this podcast is about as well as a general conversation and, meet the real people behind the scenes like we're doing now. So that's really helpful, really good.
Oh, thanks, Luke. Happy to chat anytime. I think, it's a great opportunity, and it works both ways, of course, because as scientists, many of the people I'm collaborating with are, of course, practicing clinicians, and it's really important for us to understand what it is that you're observing clinically, because I think it's only with our combined knowledge and expertise that we're really going to achieve gains in terms of the patient experience and improving quality of life for I suppose us all moving forward.
Yeah. I've got an episode title for us: "The Hips Don't Lie." No, the hips sometimes lie. I used to go in there, right? And you see yourself and Kim Allison and Michelle Hall there as well. You're doing hip, and Michelle was doing knee-related research, and you're doing hip research, and always do the Shakira joke. So the hips sometimes lie. Sorry, Shakira. Hip biomechanics and muscle function.
That's right.
If anyone clicks on it,
Shakira in the background music, the cue the intro music of Shakira.
I'm sure I don't have the copyright. Shakira will ask me for $1. I have to tell her that there's the podcast is free and doesn't advertise. I can't pay you. Sorry, exactly. Shakira.
Yeah. You just hope that she mightn't find out, I suppose.
Exactly.
Yeah.
So look, that's really good, Laura. There's some really nice to actually hear from someone who's running this research and doing these and asking these questions and doing this biomechanical research, who can explain it so well in terms of what it means for practitioner and students. And we got to really talk about applied anatomy and biomechanics. I just had one more thing I wanted to mention. The fine wire EMG study you were talking about earlier. So when I had that done, by the way, we're talking about the deep hip muscles. Let's name them. Let's name our stars of our show here.
Yeah. All right. Well, we didn't. I can tell you what we measured. You had wires inserted in obturator internus. What else did you have in that study? Posterior glute med. You had piriformis as well.
I'm getting PTSD flashbacks.
Yeah, I was like, I can see on your face that and quadratus femoris. I think you had for that particular study. That's largely where we've focused our energy for lots of different reasons. But yes, I'm sure, Luke, we're always getting ready for new experiments. So you'd be welcome to fly up to relive your experience anytime.
This is a call to action for the podcast. You can head up to Griffith, head up to the Gold Coast, have a nice holiday, and have some fine wire EMG on your glute muscles.
Well, that's true. I mean, but in all seriousness, if people are going to be up here and interested in learning more about our research center and other, not just my program of research, but others here, of course, we'd be delighted to have a chat. So I'm sure Luke will share my contact details.
What's your preferred way to be contacted? You can obviously Google you and find your homepage at Griffith.
You'll find my email, on the Griffith University website. And happy to be, I do try for a quick response rate, so I'll do my best. And I guess the last thing I was going to say, Luke, was that I think is kind of exciting and important for future clinicians or currently practicing clinicians is, technology. It's changing at such a rapid rate, and we have wearable technology now, integrating, big data, machine learning from big data sets, and really cool applications that allows us to potentially in the future take the sophisticated biomechanics analysis that we now is restricted to the lab out into the clinic, and then eventually directly to the patient's home, where we could in real time understand what they were doing. And, we have co-designed some of these with physios in Australia, and it's always great to get feedback on where people see potential uses in their clinical practice in terms of, I love the idea of being able to measure a patient right in front of you as they're performing the exercises and realize, oh, actually, they're not recruiting that muscle the way that I thought they were. It's in some ways, I suppose, similar to the way that ultrasound can be used, but taking that one step further, and then also giving patients, wearable tech to wear on their own and monitor themselves through a period, perhaps between sessions or even longer than that. So,
really close the gap. Yeah.
Yeah, it's exciting, and watch this space. Obviously, lots of clever, innovative people around the country and internationally solving this problem. So I think it's, as I said before, it's about being open and interested in learning what's out there and how it might add value, I suppose, to your practice, not just the scientific evidence, but the potential for innovation.
That curiosity that you're open with. Yeah.
Exactly right.
Fantastic. Thanks, Laura. I reckon there's I always say this, I reckon there's part 2, 3, and 4 in the future. There's always so much more we can talk about, but that's a really good introduction to you, to listeners, and also some of the fantastic work you and the team are doing at Griffith and what you've done in your research career so far. It's really interesting. So thank you.
Thanks, Luke. Thanks for having me. It's a pleasure to be here.
So until next time, this is Laura and Luke wishing you all the very best with your studying, professional development, and lifelong learning.